Eligibility considerations for special education, diagnoses versus categories, with Sara Rich, PhD, April 9th, 2025, SERC's Wisdom Wednesday webinar series.
We are so grateful to have Dr. Sara Rich here today. We've been able to work with Dr. Rich on a couple of things together, actually, over the years. She's been very helpful to our agency, our hearing officers, and other parties, providing some trainings for us. So, Dr. Rich, we're so glad to have you here. She is the Clinical Assistant Professor in the OSU Department of Psychiatry and Behavioral Sciences. And she is going to take a deep dive with us regarding diagnoses and then IDEA categories for special ed. So, Dr. Rich, take it away.
Perfect. Thank you, Dr. Conch and Dr. Hyder. I appreciate that. I am so happy to be here with you guys, whether you're watching this live or the recorded version. We are going to be talking about kind of this um, two different areas where our kids often receive diagnoses and supports and how they don't always overlap as consistently as we want them to, and helping try to navigate those systems with our families and teachers and providers and what that looks like. So I am a school psychologist, nationally certified school psychologist, as well as a licensed clinical psychologist. And so what that means is I get to have my feet in both worlds. I worked as a school psychologist for a couple different public schools in Oklahoma. I have also served as faculty with OSU School Psychology Training Program. And my current position is more of a clinical position where I am meeting with families, doing those evaluations for special education services. Those of you who are out in schools may have gotten my reports before. And so that is more my clinical role, but I am also supervising graduate students who are in the school psychology program. And then I'm also the the Oklahoma representative for our National Association of School Psychologists. And I mentioned that because recently, back in this fall, I was at our national leadership meeting, and this very topic came up as we were really trying to define the role of a school psychologist in what does that mean broadly across our nation. And there was some debate about, do we say we diagnose or not? And so in some states, that's really critical for them to say they diagnose because it gets some Medicaid benefits and other things. But traditionally, school psychologists have really in the schools focused more on categorization. And so we're going to talk about those distinctions, where they overlap, and where there might be some things that maybe are surprising to you of how those different categories are made. Throughout, please feel free to put questions in the chat. And I know Allison will be monitoring that and popping in as needed. I want to make sure this is beneficial to those of you who are joining. And we should have time for questions at the end too, but I'm fine with answering them as we go as well. So hopefully by the end of today, you will have a good kind of understanding of that distinction between what we call like a medical diagnosis and a special education eligibility category, and how they impact service qualifications, and gain some insight into the evaluation process and where those things overlap. We're going to review a case example, and then we're also going to learn how parents and educators and medical professionals can work together. And I am seeing this like yellow orange box. Are you guys seeing that on my screen? Okay.
I don't see it.
Okay, all right, that's fine. I just want to make sure it wasn't covering anything up for you all. Okay. So diagnosis and eligibility, kind of getting into what is this versus, medical versus special education. So this is, if you have seen anything from me or my colleague who does presentations with me sometimes too, Dr. Stein, this is almost always in our presentations. And I actually get the pleasure of talking with future doctors here at OSU, the medical students as well as residents. And I always show them this slide because I think not enough medical professionals understand this. So when we're talking about the clinical setting, whether that is a pediatrician's office, a family medicine office, or a clinical like psychiatry or psychologist office, like what we have here where I work, We have to use the DSM-5 for those diagnoses. This is a medical, it's actually from the American Psychiatric Association, so medical diagnoses. It overlaps with international codes for medical diagnoses. And it's really focused on, these are very specific criteria. Does the person display that? And I'm going to get into some more broad things, but basically, do they fit into these criteria? It's done by licensed professionals, so a medical doctor, a psychologist, sometimes a licensed practitioner in counseling or social work will also make these diagnoses. And the thing that I always emphasize to parents as well as physicians and teachers is that an IEP does not equal a medical diagnosis. So just because someone has an IEP, that doesn't mean they're going to meet a medical diagnosis. And then on the other side, we have the categorization. This is all under that IDEA, Individuals with Disabilities Education Act. We're categorizing services. For this one, they have to have, we call it a disability in IDEA, which I think is where it gets confusing. But really, to meet criteria, they have to meet whatever's listed out in the state policies and procedures that's developed from that federal law, and have an educational need that is so significant that they need special education services. The team is a team decision. It's not one individual who says this. It's part of that IEP team process. And then the same thing, a medical diagnosis does not automatically equal an IEP. These things are not just, you can take one and swap out the other for most cases. So wanted to let you guys, I think this is probably primer that most of you know. We're going to dig in a little bit deeper now. So when you, yeah.
I do want to jump in, sorry if that's okay. In terms of educational need, sometimes I think based upon calls we get, it's schools and parents sometimes who will kind of get that a little tripped up. Educational need could mean more than just academics, right? So they could still look at those other areas like communication, behavior. They may need specialized instruction in other areas impacting their educational day, not just their academic performance.
Yes, excellent question. I don't have too much on that, so I'm glad you brought that up. So yes, educational need, what the guidance that has come out of the U.S. Department of Education has been pretty specific that schools have to consider more than just academics. So if their behavior, if their social, their communication is affecting their ability to make progress in school, and that's more than academics, then they could qualify for services. So absolutely. And I am, as you were saying that, I'm kind of scrolling through, and I might find this here in a second, but there is a handbook for autism that the Oklahoma State Department of Education has published, and that does a pretty good job, if I can find the reference to the page, of kind of saying what that might look like in school and what that impact might look like. So like many students might have expressive communication that affects their ability, or they might have, you know, trouble really understanding instructions from a teacher. Things like that could affect it.
Thank you.
Yeah. So with that DSM, when we dig into a little bit more, what does it even mean to have a DSM diagnosis? That book, which is really thick, is trying to define what we call like mental disorders, where there's really significant disturbance at what, again, kind of clinical level, meaning it's disturbing a lot of areas of life in the areas of cognition or IQ, kind of thinking, emotion regulation. So how well I regulate when I'm upset. Do I go from 0 to 60 very quickly? Behavior, is it impulsive? Is it abnormal or atypical and causing disturbances? And that dysfunction represents something that we think is underlying. We don't always know what that underlying condition is, but we think it's something affected psychological, biological, developmental. So really saying there's something going on internally with that person that's disrupting a lot of areas of their life. The other piece that it mentions is that when we're making DSM diagnoses, we have to consider what we call clinical utility. So like how's this diagnosis going to help this person in the future? So we think about, does it help with their prognosis, their treatment plans, getting them access to services, the outcomes that they would have? I have a lot of different children come in my office that I could, if I was just going check mark, I could give them 5 different diagnoses, but giving them 5 different diagnoses isn't necessarily going to help them. And so thinking about the treatment utility of that. However, and this is a key point, the DSM does not say that a diagnosis is equivalent for treatment. And in fact, it goes on to say that there are individuals who might need treatment, but they don't meet all of these diagnoses. They don't meet all of these checklists. And so I think that's really important when we're considering categorization versus DSM, is that we're hoping it helps with treatment, but there are individuals who might need treatment and not have that. You could also have reverse. It's probably less frequent that you could have a child or an individual meet a DSM diagnosis, but they don't necessarily need a lot of treatment at this time. On the other hand, when we're talking about IDEA, this is really emphasizing they have to have a documented need for special education and or related services, depending on where they qualify there. And that need for treatment is essential to the quote unquote diagnostic process or categorization process. So this is that key distinction, is that it's all entangled when we're looking at special education. So to kind of put that juxtaposition here a little bit more clearly, when we're talking about DSM, the need for treatment and diagnosis are related, but they're not dependent on each other. They're still separate, right? We could have treatment without diagnosis. We could have diagnosis without treatment. However, when we're looking at IDEA and special education services, you have to consider that need for treatment or special education services. And again, that doesn't have to be academic. It can cover a wide variety of skills that child needs to be successful in school, but it is dependent on each other. So you cannot have one without the other. So there are some kids that have DSM-5 diagnosis that don't have that need for treatment in school. Okay, so just kind of putting that out there. Any questions there before we get into like specific categories?
When you talk about treatment, like if they were to come to your office or their pediatrician or whoever and get the diagnosis and not need treatment, that means they may not need like actual medical treatment related to that, whether that be some sort of private like clinical therapy or medication or anything like that. Is that what you're alluding to there?
Yeah, correct. So yeah, great question. So that treatment in the clinical setting could look like medication. It could also look like referrals and then therapy related to behavior, speech, occupational, those type of things. So yeah, absolutely.
Okay, and so if they weren't going to benefit or need those additional treatments, maybe they've got great compensatory skills, they meet that criteria, but they're not needing those extra supports, is what you're saying.
Yeah, exactly. And so like a child who might meet our DSM diagnosis, but also is getting special education services and everything that they're needing is kind of being by the schools addressing it. Or like you said, they've got really good, they've been in treatment earlier, they've developed the skills, they're much more in kind of a maintenance level there. So they might not need to continue speech therapy or behavior therapy or those things.
Okay, thank you.
Yeah. So now I'm going to jump into kind of the details, a little bit of the nitty-gritty of what does it mean when this overlap of the specific categories. I'm not going to go through all 13 IDEA categories, but the ones that most commonly overlap with our mental health disorders in the DSM. So when we're doing this, I do want to make just this blanket statement that when I talk about the specific criteria under IDEA, I am making an assumption, I didn't put it on all of my slides, that they've established that need for specialized instruction. So the evaluation has said, yes, we need specialized instruction, and that there's been a rule out that educational need is not due to lack of instruction or lack of exposure, or limited English proficiency. So those are two things that IDEA and Oklahoma's policy and procedures are pretty clear about, that has to be documented, that we've considered those things and ruled them out. So the first one, which gets probably one of the more controversial ones, is autism. So one, you'll see we call these things different, like we have different nomenclature in the DSM versus IDEA for very similar things. And that just right there is confusing, like just starting off from that point. So in IDEA, in special education schools, we call it autism. The DSM calls it autism spectrum disorder, or ASD. Several years ago, it's been about 10 years now, maybe longer, maybe 15, I can't remember exactly. The DSM revision that came out combined all of these different sort of autism-like disorders into autism spectrum disorder, saying it's all kind of fits under there. The schools have already really been doing that for quite a while, that we associated it quite a bit of. There's lots of autism looks very different across different individuals. When we look at the specific like check boxes of what does it mean to have autism in these two different settings, there's slight variations. School focuses on those deficits in verbal and nonverbal communication and difficulties with social integration. So being able to really develop and maintain friendships, have those social interactions with others. The DSM-5 says you have to have all three of these criteria. You have to have deficits in that social emotional reciprocity or social integration, similar things. Nonverbal and verbal communication, which is kind of combining these next two, and then deficits in developing, maintaining, and understanding relationships. So you have difficult, like this is affecting your ability to have friendships, maintain friendships, understand your role in those. And then the last piece is restrictive and repetitive behaviors and or sensory issues. And so this falls into like what we kind of think of as like stimming behaviors, like hand flapping, rocking, restricted interest. Everything's about Harry Potter, everything's about trains or dinosaurs, that kind of stuff. And needing routines and schedules very consistent, and then being overwhelmed or underwhelmed by sensory input. IDEA does not have that restrictive and repetitive piece as a diagnostic or categorization criteria for autism, but it does say that it's associated, and kids often have that with autism. And then DSM also notes that there's intellectual language impairment, motor deficits that often are associated with autism. So not huge differences here, but again, just slight little bits where the criteria for the DSM slightly more restrictive in that you have to meet all these categories, whereas the IDEA is more focused on the social communication piece, but then you have to have the educational need for services.
I think that's where a lot of people get tripped up, because when you look at the diagnosis, technically they're supposed to meet more criteria, right, to meet the diagnosis versus potentially for the IDEA category. And so you might have a child who's like autism level 1, for instance, with the diagnosis, it's high functioning, and their needs may be sufficiently met through like a 504 plan, for instance, because they've got an impairment, it is impacting them, but maybe not to the extent that they require that specialized instruction, that key component, right?
Yeah, absolutely. And if you actually look at so the DSM has like these levels of autism, and sometimes those are misinterpreted as like levels of severity, which they're somewhat associated with it, but it's levels of need for support. And when you really read into the level 1, what it says is if you have appropriate support, then individuals may not even recognize you have autism at first. And so I could very much see, an individual that maybe had some good early intervention, they've developed skills, they're at that level 1, they're able to be pretty successful in school with accommodations through a 504 plan, and or opposite, where they might start with a 504 plan, but as, you know, transitions in middle school get harder, they might need more support like special education. So it could go both ways, and that need for services might change throughout the child's lifespan. Um, and then kind of moving on to, so intellectual disabilities. This is probably the one category that has the most consistent overlap between DSM and IDEA. So we call it intellectual disability under IDEA. We call it intellectual developmental disability with DSM, but pretty much the same thing. The criteria for either categorization or diagnosis is significantly low intellectual functioning, and both Oklahoma's policy and procedures as well as the DSM define that as a score of 70 or below on a standardized IQ test, with some confidence interval looking there. So kind of up to 75 would still be within that range if everything else is consistent with that intellectual disability. And then also deficits in adaptive skills. So some sort of standardized measure of like a Vineland or I can't remember the other one that is common, ABAS. So one of those that's common standardized measure from multiple people. The one thing I will note is that the DSM also has this category of global developmental delay, which sounds a lot like IDEA's developmental delay, but it's not. Global developmental delay is basically saying this is a child younger than the age of 5 who we're starting to see signs of an intellectual disability. So they're low IQ, low adaptive, their milestones are starting to be delayed, but we don't want to put that full heavy diagnosis of an intellectual disability on them yet, because we want to give them time to catch up through early intervention when we want to reassess. And so if you do in the schools get that global developmental delay paperwork from an outside evaluation, that would translate either to intellectual disability or developmental delay, depending on what the school uses there. All right. The big one here, specific learning disability. So in schools, we call it disability. In the clinic setting, we call it a disorder. That's just, I don't know why they chose one over the other, but that's how we did it. And as you all probably know, in the schools, it's a complicated process to diagnose a specific learning disability, and wide variation between district and district. Oklahoma specifically is looking for, using that more response to intervention model over the next 8 years that every school will be doing that. But it's deficits noted within psychological processes, basic psychological processes, and deficits in listening, thinking, speaking, reading, writing, spelling, or math. And then the DSM, we have deficits in reading, written expression, or mathematics, and they're significantly below their age. Both of these documents include a lot more language that I did not want to put on here because it does get complicated, but I will say, kind of moving on, same topic here, is that really there's kind of special circumstances around these. So in the school, in Oklahoma at least, we can't, well, this is nationally, we can't require a school to use severe discrepancy. And then schools may use the RTI, or response to intervention model, or evidence-based research model. It also includes what they call perceptual disabilities, brain injury, minimal brain dysfunction, dyslexia, and developmental aphasia. That's all within the category there. When we look at DSM, they say that to make a clinical diagnosis, you need to show that the learning difficulties persist at least 6 months, despite the provision of interventions that target difficulties. So basically, they're saying you need a response to intervention, and that it does include dyslexia and dyscalculia. So I just want to emphasize this, that for me as a clinician, I hardly ever make this diagnosis in a clinical setting, because I hardly ever have documented 6 months of, provisions of interventions and response to intervention, progress monitoring data. but I'm looking at that very much from a school psychologist lens and knowing what that might look like in a school. Other clinicians probably are going to be more willing to make this based on kind of parent input of, oh yeah, they've been in tutoring for 2 years and they're still not making progress. So just know that from the clinical setting, we're somewhat limited in the information that we can receive in really making this diagnosis. Also, whole other topic that we don't want to get into necessarily, but I'll put out there that insurance companies, especially like Medicaid, Sooner Care, are not going to cover an evaluation just for a learning disability in a clinical setting. They're going to tell the parent and the provider, no, that's something the school should do. And they see this really as a responsibility of the school. So I just want to put that out there too, that if you are in a school setting, it is definitely something that is seen as the school's responsibility to evaluate for a specific learning disability from that kind of area there.
Sarah, I'll say, I appreciate you saying that you won't typically give that diagnosis from the clinical setting, but because of the access to the interventions, and you are correct, other providers do. And then it really trips up parents coming to school because, again, there's those different markers where if a clinical provider sees signs of dyslexia, then it's brought to the school and they think automatically now, oh, dyslexia falls under SLD, which it does, but there's these other indicators they have to meet at the school that maybe that outside provider, didn't consider, didn't have access to. And then the parents are being told, oh, your kid can go get an IEP. And that's not always necessarily accurate because of these other indicators. And it does create a big barrier and lots of confusion.
Yes. Yeah. I mean, so confusing. And I think, we here in Oklahoma are having even more of this come up because of the screening for dyslexia. And that just is adding another layer of complication. And what I'm finding is that, parents go to their parent teacher conference, they get that piece of paper that says dyslexia and they take it to their pediatrician. And then their pediatrician says, okay, I know a psychologist, and then they send them over to me and I say, you need to go back to the school. So it
Right.
is a piece of it. And I am in my little OSU world, I'm really trying to educate our pediatricians of, nope, don't send them to me. Here's a letter, send them back to the school. And this is what it means. But yeah, you're right that there's just needs to be a lot more education for our clinical providers on what does a school have to document for specific learning disability. No. So this one definitely is the most, I think, confusing to everyone involved. So speech language, and I will put the caveat of I am not a speech language therapist, and so I'm sure my speech friends have a lot more to say about this. But in IDA, we call it speech language impairment. In DSM, there's actually 3 different disorders that might fit under this. So there's just kind of broad language disorder, which we used to call mixed receptive and expressive language disorder. Now you make a specification of that. There's speech sound disorder, which is more like articulation errors. And then there's what they call childhood onset fluency disorder, which is a fancy way of saying stuttering. So all of that's in the DSM. And then it has, kind of the difficulties depending across those of, normal speech fluency, how well you can understand them with that intelligibility, and then the way that they're using expressive and receptive language. All of that is kind of consumed under that communication disorder within IDEA. And so there's, again, a lot of overlap here of those categories, but there's probably specific, again, if they went to an outside speech therapist, insurance is going to dictate some specific levels that they have to have in order to meet these criteria. And the schools are going to be looking at those levels as well as educational need. And I think that's, again, sometimes I'll hear from parents, they qualify for speech therapy outside of school, but not inside of school because of that educational need. And then traumatic brain injury, which you would think would be pretty cut and dry. And it is overlapped quite a bit, but it's a lot of fancy language and a lot of documentation is needed for this. So IDEA, we call it traumatic brain injury, nice, simple. DSM likes to complicate things, so they call it a major or mild neurocognitive disorder due to traumatic brain injury. And so just to give you a little bit of insight, that mild or major neurocognitive disorder, that's a broad category in the DSM, and it can be due to Alzheimer's. It can be due to Parkinson's. So it can be due to lots of different things. So this is just saying this one's due to traumatic brain injury. I won't read you all of the different components here, but just so you know, it's really both are saying there's the IDA is more focused on there's a brain injury and it's affecting impairment in some way. Both focus on it's what we call acquired, meaning it's not something that just they were born with or that even happened during birth, which is another specification, but it's something where something actually happened, an injury happened to that person. They say open or closed head injury, meaning whether or not like skin was broken versus not, whether it was like a concussion and the brain was rattled around, all of those things. So as you can imagine, in the school setting, you're going to need some sort of medical documentation of what happened, what is this, what's the current functioning. And then within DSM, there's lots of different specifiers of, was it rapid movement, displacement of the brain, all of that. And again, if I'm looking at traumatic brain injury, when I'm talking to my neuropsychologist friends, and then I am also looking at all the medical records. DSM does note that you have to have some deficits documented kind of immediately after that TBI, and what that looks like. And then there's all kinds of, was there concussion, loss of consciousness, that kind of stuff. And then the IDA does specifically talk about that. It's not something where a person is just losing cognitive functioning over time, like we might see with Alzheimer's or Parkinson's, those type of things. And for our children, that might be something associated with a genetic condition like Down syndrome or something where we start to see some decline in cognitive ability over time. That's not considered a traumatic brain injury by IDEA. All right, so I'm going to go into some other kind of reverse this and talk about other DSM categories and where they fit with IDEA, but I just want to also note that there are obviously more IDEA categories that I didn't cover, like, vision and hearing impairments, orthopedic impairments, and those have a little bit more just direct like medical tie, and they're not necessarily like mental health disorders. Okay. So when we are looking at that DSM and where that overlaps and where it might fit in, and again, this is really up to the team to look at the criteria and see where it fits, but you might have a child come with an outside report that says they have what we call social or pragmatic communication disorder, which sounds like it would be maybe like a speech language thing. But what this really is it's like the child has social deficits, communication deficits, very autism-like in their presentation, but they don't have those restrictive and repetitive patterns of behavior. So it's really something that's just affecting their social and communication, not so much like the rigidity of needing everything consistent, the black and white thinking, that piece of it. So with that, a school might say, yeah, that, this child meets our IDEA definition for autism and they need services. It might be more of a social situation that it fits more under their social language for speech language. So could be either way. Attention deficit hyperactivity disorder, we tend to do other health impairment for that one. So that tends to be the go-to. It is listed in our policies and procedures, so that might be part of it. Then there's motor disorders like tic disorders or coordination disorders. Those are things that might fit under health impairment. They could also, just depending on the severity and what it's affecting, could be an orthopedic, especially if there is some need for PT in there, but again, affecting education in some way with that. And then this is really broad list of kind of a catch-all of not everything, but like I said, the DSM is really thick and we can make a lot of diagnoses with it. But any kind of schizophrenia spectrum disorders, other psychotic disorders, IDA is pretty clear that that's an emotional disturbance. Like that is yep, you've got schizophrenia. It's really hard to have schizophrenia and it not affect your education. That's emotional disturbance. Other ones like bipolar, depressive disorders, which I will put under depressive. I didn't list it out specifically, but it's disruptive mood dysregulation disorder, which is a type of depressive disorder, DMDD, anxiety disorders, obsessive compulsive and related disorders, and trauma and stress related disorders like PTSD. Those may fit under emotional disturbance. And so that's usually what we're looking at. Any thoughts or comments on that one?
Yes. I think this is from both sides of the coin with the parent and the school. Sometimes with the anxiety and depression diagnosis, people are really reticent, whether that be the parent or the school or both, to look at that emotional disturbance ED as the category. I think because of this perspective, misconception that like, oh, if they're ED, then that's like this outward behavior. Those are like the bad kids. That's not the case. I mean, this is all related to some sort of disorder, right? And so I think a lot of times people are really hesitant to move forward on that. And it's as if that's going to cause an issue. But if that disorder, that diagnosis, right, like their anxiety or depression is creating such an emotional difficulty that requires some instruction, it's impacting, then it does fall under that category to consider. Have you found that you've had to talk to like any clients that have come through your clinic where maybe they're hesitant about this regarding especially those two? That's where I've seen a lot of hesitance in the schools.
Yeah, absolutely. And more when I was in the school setting and making that, and it felt, I mean, this is not a professional term, but it felt icky. Like it just felt like I'm saying like there's some stigma around emotional disturbance. But if you go and actually look at those criteria, I mean, it's very clear that it is like emotional issues that are affecting school. And probably the most common one that I've or example that I kind of tell parents to maybe ease it is, think about those kids that have such high anxiety that it's school refusal. Like they're not getting on the bus to go to school because they have such high anxiety, or they won't even walk through that front door. That's an emotional issue. That is an emotional regulation issue that is affecting their education. And depending on what the school's tried and counseling and other things, but that very much could be something that would qualify for an emotional disturbance and an IEP if that's the level that the school needed to implement to reduce that anxiety. And so yeah, I do think that is I think the disturbance part of it is maybe what gets there. And I wish they came up with a new name for it, because it does feel like, oh, you're saying like they have schizophrenia or something like crazy. And it's not that. It is very much their emotions are not in that typical range and it's affecting their school.
Right, exactly. Yeah. And I think it's that externalizing behavior that for some kids that have, now you've associated the stigma with it, and that the anxiety stuff is usually more of that internalizing. So it's just really interesting how people, there lots of weight is given to that category, it seems like, and so people are really hesitant to move forward.
Yeah, they are. And I just, to be honest, when I was in the schools, I negotiated with some parents and I'm like, look, would it feel better if we said other health impairment? And we went with that. And the services look the same because category shouldn't drive services. But I also understand, from the school perspective, it's better to have an accurate reflection of the resources being needed. So.
Right. Well, and someone has actually asked, one of the attendees has asked, could it not be other health impairment with anxiety or depression?
And I think it could, kind of depending again on the level of services and supports. But if you're having, a teacher that you're dedicating full time to, and it's a pretty high level of support, then you need to accurately document the level of resources that are being used for that. And so that is something that, it's kind of hard to talk about, but in schools, like these different categories get different funding because there's a recognition that they might need different level of support.
Hmm.
Yeah, but yeah, I could definitely consider other health impairment as well. All right, and then this one gets even trickier too. So we have this category in DSM called disruptive impulsive conduct disorders. So this is oppositional defiant disorder, what we call intermittent explosive disorder, which is like just on a drop at a hat, they explode. They're not chronically irritable. Chronically irritable is more like a depressive disorder, but like just a drop at a hat, they explode. And then conduct disorder, which is more of that kind of sneaky lying behaviors, that type of thing. So this again could be emotional disturbance, and we've made that emotional disturbance category kind of the conversation we were just having, more of a behavior type situation, and it could fit there because these are behaviors that are not typical under normal circumstances, which is part of the definition. You could also do other health impairment. There's always this social maladjustment, and just to be honest, I mean, I've been to so many trainings on what is social maladjustment. I don't feel like anyone has a good definition. I think to me, is it situational? Like, is it only with this one setting where we're seeing these behaviors? Then that's a social maladjustment. If it's occurring across settings and having a significant impact on their life, then we might be looking at something more than just kind of that social maladjustment. But again, really hard. That is a clinical kind of judgment thing or a team judgment, depending on the setting you're in.
Sarah, with the oppositional defiant disorder, and this is, you hear a piece of information years past, and I really don't know if it's accurate, but I've always heard that oppositional defiant disorder, that ODD, doesn't, and you'll have to confirm if it's accurate or not, doesn't typically occur on its own, that it's usually the result of some other ongoing thing. Is that true or misunderstood?
That's a good question. So we know that it does co-occur pretty frequently with ADHD. And so those two go together. And I would say it probably is more atypical just to have ODD on its own, but that doesn't mean you can't. So yeah, so I think I would word it that way. Is a lot of times we do see it connected with ADHD and more frequent. I also see, kids may have gotten that diagnosis at a very young age, but after they're a little bit older, you're like, no, this is just the impulsivity with ADHD, and you change the diagnosis there. But they go together a lot of times.
Okay.
So that's kind of, again, getting in, that's all the information on like categories, how they overlap. I think the big thing is it's a team decision, and it's really, you have to look at that. So I'm going to quickly go through a little bit of kind of what do the evaluations look like in these two different settings. There's actually quite a bit of overlap. So when we're in the school evaluation side, that referral is usually from a parent or a school personnel. So that's who can request an evaluation. In clinical, usually the referrals are coming from their primary care physician. Again, kind of like I said with dyslexia, usually because parent comes in and says, the school tells me they're having this problem. And the parent says, okay, I'll send them to the psychologist. Parents can also self-refer to for behavioral medicine services or an evaluation. In the schools, we touched on this already, but it's very much a team decision based on that educational need and disability. Whereas in the clinical evaluation, it is the person doing the evaluation. It is not a team decision. Some clinics do use a multidisciplinary or transdisciplinary team, especially for things like autism, but ultimately it's kind of that provider writes the report with their conclusions. We do qualified examiners in schools. So this might be, again, a team approach of a school psychologist, psychometrist, speech language therapist, occupational physical therapist. Whereas in the clinical setting, it's going to be whoever that licensed specialist is, either a psychologist, speech language, occupational physical. I didn't put my colleague psychiatrist on here as well, but psychiatrists, they usually don't do the more in-depth like IQ testing, but they can make diagnoses with that. School evaluations, again, each state has its different policies and procedures. Oklahoma has an evaluation handbook that specifically details what needs to be included depending on what category you're using, but just generally there's some sort of academic assessments, observations of that child within the academic setting. That could be the classroom, but also hallways, playground, lunchroom, looking at those other areas, and review of any previous learning data, and review of educational records. For the DSM, really, we're just doing whatever we need to do to collect the data depending on the category. Almost always diagnostic interviews and rating forms. Sometimes we're doing a little more what we call kind of neuropsych evaluation measures here. So that might be like directly measuring attention skills or directly measuring memory, that kind of thing. And then what's common across is any good clinical or school evaluation is going to have interviews, rating scales, observations. I can't observe them in the school in my clinic setting, but I am going to have some sort of observations and some sort of standardized one-on-one assessments that we're doing with the child.
Do you mind going back just one slide real quick?
Sure.
One thing I have seen happen from my previous experience in school districts, and even when we get calls and parents will send us like reports they've gotten or whatever. The outside clinical evaluators, I mean, there's obviously overlap, right? Like an OT, PT, speech path, psychologists, of course. But when you're looking at what those experts and qualified professionals can do in a clinical setting versus who can sign as the qualified examiner, depending upon the category in schools, it's very different. So we've seen where like my background is speech language pathology. So in a clinical setting, I could do certain assessments that in the school I couldn't sign off on because of IDEA rules. Same with occupational therapists. A lot of times they'll do some tests and maybe a parent will go and have paid for an evaluation that an OT has done everything. And they'll take it to the school and the school will say, oh, we can't accept this because in the school, they're not a qualified examiner for these things. So I think that's also really important if parents do get outside information that they know whether or not that diagnostician is actually able to do those things in a school setting, if the school can accept it or not. I don't know if you've run into that, if people have come to you or when you were in the schools.
Yeah, I'm glad you brought up that point. I have not run into that as much. I think where I've seen and people have asked me the question is a lot of that sort of dyslexia testing again, because a speech therapist or occupational therapist outside of the school could be, like you said, like a certified dyslexia therapist and evaluator, and then they take that to the school and the school's like, we don't know who this person is. And so I see it with some of those assessment measures where it's like a different level of person. And I don't know, I think this is more your area, but I would say if the person was qualified to do the assessment, the school should still accept the scores. But I also understand, and which I've got here on one of my next slides here, that you should be considering who did the evaluation. Mm-hmm. So it's kind of a balance there.
Yes.
So what happens, and this is what I go over with parents. What happens when I do have an evaluation and I do have a diagnosis? Well, technically from the school setting, then it's what we call triggered child find. That doesn't mean the school has to do an evaluation, but they have to consider, oh, is this a child with a disability that might need special education services? So what we do in Oklahoma, we complete a REDS form, or review of existing data. We document all that outside evaluation. We look at whatever we have existing. And we determine as a group, which also includes parents, do we need additional data or do we not need additional data? If additional data is needed, I tell parents, very, very common. The school will likely need to collect additional data. They won't have to repeat what we did in the clinical setting, but they'll likely need additional data. So because I'm not doing in-depth academic assessments, insurance doesn't pay for it. I can't spend a lot of time doing it. So I'm not doing in-depth academic assessments. I can't do classroom observations. I try to get teacher input on rating scales, but we don't always get what we need there. I don't have the data on progress report, current support levels, what the school currently has and has been doing. So all of that's likely data that the school's going to need to collect. And if they do, then they get consent for evaluation. Then again, Oklahoma specific, we have 45 school days. The IDAs is 60 days, 60 calendar days, to complete that evaluation. We review all the data and we determine eligibility. Sometimes, and I don't know if I have this on here. Hold on, let me make sure. Yeah, so sometimes they don't need additional data. Sometimes it's very clear cut based off all the data the school already has, is that this kid has a clinical diagnosis, it meets this criteria for IDEA, they definitely need special education services, we can move forward without evaluating. I've also had situations where the parent saying, I have significant concerns, I have this outside diagnosis, and all of our school data indicates there are absolutely no educational concerns. Attendance, grades, behavior, social, everything is normal and typical at school. That's not as a common situation, but that is a situation where a school could say, look, we could do an evaluation, but we already know they wouldn't qualify because all of our data shows there's absolutely no educational needs for this child. Probably, and Allison will probably say this, the school should probably also consider a 504 or their accommodations or other things that they should be doing at that point. And again, looking at that as well. But, and I would say that's more rare situation that happens. And then this is kind of back to that consideration. So what we've said and what's written in the policies and procedures for Oklahoma is that the school should look at the qualifications of that person completing the evaluation and where do they match with the school team. How does that school outside evaluation apply to the school setting? And then looking at those specific criteria for DSM versus the IDA, and did we get enough data to support that? This is just a brief, hopefully a good comprehensive outside evaluation will include these components. Always make sure there's scores, some sort of summary recommendations, and then there might be other assessments just depending on the referral concern and more information. Okay. Before we do a little bit of a case, anything else on kind of thinking through the outside evaluations and what that looks like in the school setting?
There's no questions in the Q&A. I think I'll just sort of, piggyback off of what you're saying, that sometimes, again, schools look at outside reports and they might need that additional data because maybe there's an area missing that the school IDEA law requires them to look at an area, like you mentioned before. And I think that's important to remember. And I appreciate you in a clinical setting warning parents like, hey, they may need to look at other stuff. Because I know that can be frustrating when parents think they've got this big thing and we can just move forward and have an IEP tomorrow, not always possible. So I appreciate that insight.
Yeah, absolutely. And I will say that, I think parents understand, and the way I explain it to them is you've got step one down. We did the IQ testing. We did all these rating forms. The school's going to be able to use that. But I wasn't in the school, so I can't tell you about the school setting. And when I explain it like that, they're usually like, oh, well, that makes sense that you'd have to get school data. So that's how I try to say it. So here's just kind of walk through a case. Let's look at Lily. Lily's 12-year-old, and her pediatrician referred her to her psychologist, and she's kind of had persistent worries, repetitive behaviors that are interfering with school and home, according to parents. Pediatrician actually diagnosed her with OCD, or obsessive compulsive disorder, and started an SSRI, which is a treatment for anxiety, depression, selective serotonin reuptake inhibitor. But it hasn't really been effective for Lily, so they referred her to the psychologist. Lily's always been academically gifted child, but struggled socially. Recently, her teachers report that Lily's become fixated on certain classroom rules and schedules, leading to frustration when things don't go as planned. At home, Lily has developed rigid routines, such as needing to align her books in a certain way before going to bed, or her parents are concerned about her distress when these routines are interrupted. Kind of clinical presentation back to the routines. She's insisting on arranging her personal items in specific patterns when she's upset, when they're moved, or she doesn't believe something she doesn't believe something bad will happen necessarily. It's just like, I just feel better when things are a certain way. Her morning routine has to be done: brush your teeth, get dressed, eat breakfast. If that gets interrupted, she gets pretty upset and may delay getting to school, having meltdowns. Really strong, enduring interest in astronomy. Like, this girl loves stars and space and everything around it. Her thoughts are about space. She's always talking about it. It's not really like an intrusive thing, but if she has the opportunity to talk about anything related to astronomy, she will. She frequently engages in repetitive hand movements like tapping, flapping, kind of just always moving when she's anxious or excited. And she says that these behaviors help manage her emotions, but they're not really filled like the need to like neutralize a distressing thought or anything. Like, if she doesn't do them, the world will end. Sensory, she reports, I just feel different than my peers. Group activities, social play, she finds confusing and overwhelming. She has strong aversion to certain fabrics, can't wear clothes that are too rough or itchy. She says she struggles with small talk and understanding others' facial expressions and body language. And she's reportedly starting to refuse to go to school because she just feels like she doesn't fit in. And it's really struggle for her. So we evaluated Lily, came up, she's got high IQ, high average IQ, full scale of 110, slightly lower verbal skills and 90, still within average range, but a little bit lower. High levels of anxiety were noted by teachers and parents on rating forms, and her own ratings of anxiety were a little bit elevated. Autism rating scales and the ADOS indicate moderate symptoms of autism. Clinical interview really indicates that those compulsive behaviors she's doing really are more like restrictive, repetitive behaviors, not necessarily obsessive compulsive, which is a hard thing to kind of differentiate clinically. So she ends up getting a diagnosis of level 1 autism spectrum disorder without intellectual impairment, without language impairment. So thinking through, Lily, what should the school do with this information? Kind of what would be the next step for the school? And I don't know if someone in the chat wants to respond, or if Allison, you kind of want to talk through where you would be on a school team with this, but thinking through, okay, clinically, we've kind of figured out it's not OCD. It looks more like autism, but this level 1.
I would think they would need to gather and review that and determine from the school and all the behaviors at the school, whether that be an IDEA read, at least reviewing that data, or through the 504 process, depending upon parents' input and the extent of the issues of the school, is reviewing that and making a determination under one of those areas. If that student needs additional assessments to look at eligibility, if you can move forward on one or the other, which they could go either route, technically. I think that's where sometimes schools don't always do the due diligence in terms of the parent has brought forth this information, now we've got to respond to it, right?
Yes, exactly. And that's like, it sounds like she's done pretty well in school up to this point, but socially it's starting to affect her. And so, yeah, we need to provide some accommodations to make her feel more comfortable at school, or is this really looking at special education services and where it's at? And so this is a parent that, again, like we were talking about, that level 1 of like, it might not rise the need to special education, but a school definitely shouldn't ignore this. If they're like, well, she's been going here fine for all these years, it's signaling we need to do something, and we need to evaluate and look more closely. And I say evaluate, like evaluate the circumstance going on. So, yeah. So kind of just wanted to throw that out to put it in kind of context of what it might look like. The next few slides, I'm going to go through very quickly because they're just the handout that I'm going to get to, and I want to make sure there's any questions or anything. I know technically this can go to 1:30, but I want to make sure there's time too. So this is based off of a handout that myself and my colleague, Dr. Stein, came up with, and we, OSU helped us, put it together in that we hand this out to parents, especially when there is those questions and just going through those frequently asked. So my child has a diagnosis, they get an IEP, right? Like that's what happens. And so we say, maybe, possibly, but the school has to determine, is it a disability, educational need, special education? Do they need special education services to be successful? Does the diagnosis from a psychologist or psychiatrist just automatically qualify as a disability under IDEA? Like we talked about, maybe. It depends. The classic special education answer, just knowing that we use DSM or ICD-10 codes, which is the the huge medical codes. There's tens of thousands of codes in there. But the school has to really determine, does it meet the criteria? What if the school says they need to collect their own data? We've talked about this. Yeah, they might, and that's fine. That's fine. They might need to collect additional data. But what if my child doesn't qualify for special education services through an IEP? Does that mean that the school's just not going to help them? I hope not, is the answer. So schools, and I think this is where a lot of parents, and I do a lot of education, is schools look very different than they did 20, 30, 40, 50 years ago. It's not special education or nothing. We have lots of options. There's the 504 plan, like we've talked about. There's interventions, both for behaviors and academics, that fall within that more multi-tiered systems of support. Schools have embedded mental health services a lot of times that they can connect them with. And so just letting parents know that the answer of no, there's nothing we can do is not acceptable. There's something they can do if there truly is some issues at school. And we do have some parents where I don't know that it's truly a home issue and there's not something that the school needs to do. But if there's some school issues, the school should be working to make sure that child's accessing education the best that they can.
Mind if I jump in real quick on the sports talked about? We get a lot of calls from parents, even in past experience working at schools, where there's kind of this misperception about 504s, like, oh, well, those don't really matter. Like, they give you the same protections for a student under 504 as they have under IDEA, for like discipline and accommodations for supports. So I think a lot of people think, well, the IEP is like the gold standard. They only need that if they need specialized instruction, and I think that's really important, because that, for some reason, I don't know, is a misperception that like, oh, my child's not protected. No, they still have procedural safeguards. It's just a different route, but they are afforded those same disciplinary behavioral supports, equal access for accommodations. That main difference is that lack of specialized instruction with the goals tied to it. So I think it's really important for people to have an understanding of that the 504 is still a legal document to support and identify your child as a child with a disability.
Yeah, absolutely. And I can't tell you how many times, whether or not it's accurate to what's going on in the school or not, but how many times parents tell me, well, they have a 504, but they're not doing it. And I'm like, okay. That's not okay. Like, here's the things to ask the school and to put it, and trying to do that education on. It is still like you said, it's still a legal document. They have to follow it. I also, and I'm sure you all run into this too, that a lot of parents really truly don't understand what an IEP is and what services their child's receiving within that IEP, because so many times they'll say, oh no, they don't have an IEP, but they go see the speech therapist this many times. And I'm like, okay, where are we at here? And the category of services is very rarely do I have a parent tell me, oh yeah, they're categorized under this. And it's not, I just, them truly understanding those documents and what they mean is a huge, I think, area that school professionals, we can do better in educating that piece of it. So, and I also get, it's a lot of information for parents. Like, we might not have to tell them multiple times because it's a lot to take in at one time.
Yeah.
So if a parent disagrees with the school or is having some of these issues, what can they do? Well, there's SERC, but I always tell parents, first, have you talked to the right people at the school? Have you talked to the special education teacher, the special education director, school psychologist? Like, who have you talked to at the school? I really find that most schools, they want to work with parents. Like, they're not trying to be adversarial to parents, and they want to do what's best for their child. And encouraging parents, again, like we were just talking about, I think a lot of times they get overwhelmed in those IEP meetings and don't feel like they can express their concerns. And so encouraging them to, you're your advocate for your child, and speak up, tell them your concerns, and that they should have the option to complete, a comment form on there, and keep refocusing on what's best for the child, and let's keep refocusing on what's best for them. And it's not about the school versus parent, but what are we going to do to get them to succeed there. And then, of course, if there are continued issues, we've got SERC, and we have Oklahoma Parent Center, the State Department of Education, the Oklahoma Disability Law Center. So there are avenues for parents to reach out, and they're not alone in this space, is really what I encourage them with that. So key takeaways: DSM and IDA are very different things. We have to make sure that, IDA really focuses on the treatment and the need for services. Clinical diagnoses in schools, they're going to have to review that. The evaluation processes, they're pretty similar, but schools will likely need to collect additional data. And supporting families, it's confusing, and just know that it's confusing. And you might need to provide information for them to navigate both the school and the medical setting, and multiple people might need to give them this information that we talked about today, of those differences there. So this is my contact information. I'm always happy to talk about any of these kind of issues. That QR code there will link to the handout that Rob put in the chat earlier, but it is this handout that goes over those frequently asked questions that I just reviewed a little bit more detailed. So it's a two-sided handout for parents that we give to them kind of once they've had a diagnosis there. And I will pause. Any comments or questions from anyone else?
I don't see anything else in the chat or the Q&A right now. These were great. I appreciate you also mentioning reaching out to the right people in the school district, because we have a lot of parents that will call us, and I will ask that exact question: who have you talked to? Because sometimes maybe the school team, it's trickled out of information from that district level, and especially in larger districts, it might not always get to the right people. And they may not be making the right moves, and they might not realize it. And so reaching out to the district's department is always helpful. We always ask parents who they've talked to and who, and we can help facilitate that conversation even without an official service from SERC. Frequently, I'm able to help them get in touch with people. But yeah, it is really important, because sometimes it can be resolved just right then and there. Internally, which is always great to be able to move forward in that partnership.
Yes, absolutely. And I think that's better for everyone involved if they're able to resolve it kind of on their own. And so they're really working in that team process then. And it truly is. I mean, general education teachers don't get a lot of information on this kind of details. And so I think sometimes they say things to parents take it escalated or take it out of context, and then we just didn't have the right people at the table talking when they needed to be.
Yes, exactly. Well, this was wonderful. Thank you so much, Dr. Rich. This was so great. I appreciate all the insight. This is such a confusing topic. I mean, even for school districts too sometimes. So thank you for providing this